Hello, everyone. Welcome. Welcome, everyone, to our SPR webinar, our mid-year webinar, almost halfway through 2022. Perfect. Well, so while some people are still logging in, I'd like to thank you, everyone, for joining us. Today, we have a great presenter that's going to share her work with us. She is Dr. Anna Babl. She's going to be talking to us about psychotherapy training, a 21st century principle-based approach. And before I let you hear from her, I would like to tell you a little bit about her. She's a postdoctoral psychotherapy researcher, and she has just started working this June at Adelphi University in New York, working with Catherine Eubanks. Previously, she was working as a postdoc at the University of Bern in Switzerland with Thomas Berger. And well, Dr. Babl has investigated psychotherapy integration, defensive and reflective functioning, as well as a variety of interpersonal aspects of psychotherapy. In her new project, she will be focusing on understanding and training the therapeutic alliance via rupture and resolution processes. So Anna, it's a great pleasure to have you here. Thank you very much for sharing a little bit of your work with us today. And to our audience, you are going to have the chance to speak directly with Anna throughout different moments of the presentation. There are going to be some very interactive moments, so we encourage you to turn on your microphones or write to us during the chat box. And also, if you have any questions throughout the presentation, please don't hesitate to leave them in the chat box on the bottom of your screen. So without further ado, Anna, it's all yours. Thank you very much.
Thank you so much, Juan. Well, also welcome from my side to this SPR webinar with the title Psychotherapy Training, a 21st Century Principle-Based Approach. I would like to first thank the SPR and the Communication Committee for inviting me to give this talk, giving me the opportunity. It's a real privilege to talk about a topic so close to my heart today and in such a nice community. I was free to present basically anything today, so I decided to talk about psychotherapy training because I think it's important and an overseen topic of it, and because no one else, to my surprise, of the experts that are there in our community have talked about it in an SPR webinar. But also I wanted to talk about it because I think it will be some, well, it will be part of my work in the present and future, and actually kind of the work that I hope we will all do together to arrive at a truly research-informed psychotherapy training that provides a good model for therapist skill advancement and also ultimately psychotherapy success at the individual patient level. Previously, I have closely collaborated with a great number of students and the following senior researchers that you can see here, and most of you probably are familiar with these faces. And something that we all have in common is that we underwent some sort of psychotherapy training, which are in general extremely time and cost intensive. And most training programs focus on specific therapy schools. I trained in psychological therapy, which, if needed to be labeled, could be called an integrative cognitive behavioral approach. And then there's some representatives of psychoanalytic, psychodynamic approaches. We have Les Greenberg with emotion-focused therapy, Shelley Main, an expert in DBT, and Uli Kramer, who has done a lot with other approaches for personality disorders like clarification-oriented psychotherapy, some other representatives from Bern with psychological therapy. And I think that after my first initial training, took some further training in EFT and DBT, for example, and I think most of the people here and most of us overall have worked in some way integrative in our careers. And this mirrors also the finding, the research finding, that most therapists identify as integrative, although most training programs surprisingly do not. So given how much training is based on the theoretically specific methods, it is surprising how little evidence there is for their effectiveness, especially when comparing different theory-specific approaches. And this is something that kind of reminded me of the Dodo Bird verdict with regard to psychotherapy. And I wondered if it wondered if it might be also applicable to psychotherapy training. So originally, Rosenzweig in 1936 stated that different therapies are equally effective because of what they have in common. And then noting that the debate between common and specific factors of psychotherapy is counterproductive, Weinberger and Rasko offered an alternative interpretation of the Dodo Bird verdict, and they stated that different therapies are equally effective because they are equally incomplete. So they draw on some common factors while maybe neglecting others. Then Stiles and colleagues offer another interpretation of the Dodo Bird verdict, that is that different therapies are equally effective because therapists are equally responsive to their patients. And I just wanted to mention all these explanations in the beginning of the webinar because I think with regard to psychotherapy training, we will touch upon all of them over the course of this next 1.5 hours. However, now I would like to continue with the question, which is psychotherapy training effective? And I would like to invite all of you who may be clinicians, who may be experts, those who have some sort of experience with psychotherapy training to just share their thoughts and comments, their initial reactions to this question, if there are any. Go ahead, please.
Yes. I have been training for 30 years, and of course I like to think it's effective. But besides, no, I mean we do assess the effects on therapists, on patients. So I would say in the training when they do their practical work, that is a way of assessing effectiveness, because the range of recovery for patients is equal or above average in experienced therapists. But I would like to mention more than this, Oliver Evers, one of SPR members, study in Germany, in which he studied along 3 years, 290 therapists in training, assessing their progress, which actually was not such, because at the end they knew a lot, but they became worse persons and less empathic, which is very interesting. And they are preparing a second paper on why. And why is, on the one hand, candidates who were extremely perturbed by early trauma, especially, but what matters to this discussion is very severe and cold supervision.
Oh, thanks. That's even some news that I had not known before. So thanks so much for sharing. Anyone else? Well, I think most of us like to think that psychotherapy training is effective because most of us invested a lot into becoming a psychotherapist. Anyway, what we know so far is that novice trainees can be trained in helping skills, and that novice trainees improve in these skills over the course of training, at least on average. Then we know that experienced therapists can be trained to use manuals. And overall, and this maybe explains why we all took psychotherapy training, even though there's limited empirical evidence for its effectiveness, is that trainees value training. But then there's also some studies involving large numbers of therapists that showed no effect of therapist experience level. And other studies show that highly facilitative people who had no psychotherapy training were as effective in helping clients as trained psychotherapists. So yeah, I would say it's a careful yes, psychotherapy training is effective, if I had to pick. But I think we can all agree that psychotherapy training is complex, just like psychotherapy itself, and thus difficult to empirically investigate. and come to kind of a definite answer about the processes and associated outcomes. Yet, I think it is extremely important to come to and consider empirical findings so that psychotherapy and also psychotherapy training don't work by chance. And for that, it might be meaningful to consider principles of change that cut across different approaches when aiming to develop a truly research-informed complementary psychotherapy training. Because that was put forward before, at such an intermediate level of abstraction, it could be possible that therapists have some freedom with regard to the concrete interventions that they use, but at the same time, it is ensured that important change processes are facilitated. These common principles can be part of efforts to identify areas of unity between approaches rather than develop new training approaches at all, because I think that's not really realistic and it's not necessarily what we need. There are some previous training models that in principles of change that at least focus on one or fewer trans-theoretical and trans-diagnostic processes, and those are the alliance focused training, for example, the facilitative interpersonal skills training, the helping skills training, and the context responsive psychotherapy integration. And there may be more that I'm not going to talk about today, but those four I would like to outline a bit more in the following. I will start with the alliance focused training by Zafran, Moran, and Eubanks, which focuses on helping therapists recognize ruptures in the alliance, both through the observation of patient and therapist behaviors, but also by attending to their own internal emotional experience. And trainees in AFT practice navigating rupture moments under pressure through the use of experiential exercises and role-playing exercises in group supervision. Now, the effects of AFT were shown to foster rupture repair and patient outcome in 6 studies. Eubanks conducted a meta-analysis on that. And in another study by Moran and colleagues, the impact of introducing alliance-focused training to trainees conducting CBT was examined by randomly assigning trainees to switch from CBT supervision to AFT at different time points in a multiple baseline design. And actually, this switch to AFT was associated with decreases in therapists' controlling and blaming behaviors and patients' dependent behaviors, with increases in patient and therapist expressiveness and therapist affirmation, and also with positive treatment outcome. Then we have another promising approach to principle-based training, which is Anderson's facilitative interpersonal skills model. And these facilitative interpersonal skills include the ability to effectively understand and send interpersonal messages, as well as the ability to communicate a rationale for another's problem and to propose new and effective solutions. FIS is based on a broader definition of skills inferred from therapy processes that have been strongly linked with outcome, such as, for example, empathy, the alliance, warmth and positive regard, or persuasiveness and hope. The FIS research method exposes therapists to a simulation of therapy where they respond to standardized, realistic, and challenging patient verbalizations that are presented with brief video kind of stimulus clips. And FIS and outcome have been evaluated in various settings using different research designs. The findings of a randomized control trial by Anderson and colleagues that categorized therapists by interpersonal skills found that therapists high in FIS had greater pre-post patient outcomes than low FIS psychotherapists. And furthermore, alliance scores of patients with high FIS therapists increased over the course of treatment, while alliance scores of patients with low FIS therapists did not. And in another study conducted even also by Anderson et al., only FIS accounted for variance in outcomes, while other therapist characteristics were unrelated to outcome. In a prospective naturalistic study, showed that therapists FIS significantly predicted patient symptom change and provided some evidence for the causal role of FIS for patient improvement. And the last study on this slide that I would like to show by Purman et al. Is an RCT of brief training, testing the impact of a research-informed training protocol that integrated elements of the alliance-focused training from the previous slide and the FIS. And they incorporated empirically supported video stimulus of therapy, which were reinforced by deliberate practice on some key therapeutic interpersonal skills. And it was found that actually this AFT and FIS condition compared to the active control group showed a marginally higher level of overall and specifically targeted post-training therapeutic skills. So at least there was some skill advancement, even though we don't know yet about the relationship with outcome in this particular training. I would like to continue with the helping skills training by Hill, which refers to kind of the structured programs that teach specific verbal interventions based on the assumption that these skills are fundamental interventions in psychotherapy. And the origins of helping skills can be traced back to Rogers. However, more recently, Hill developed a 3-stage model of exploration, insight, and action. And in the exploration stage, helpers are trained to use open questions, restatements, and restatements of feelings to help clients explore their thoughts and feelings. In the insight stage, helpers are trained to promote client insight via open questions, challenges, interpretations. And in the action stage, helpers are trained to use questions, information, and direct guidance to help clients make changes. Helping skills training is widely applied to introduce students to professional training in psychotherapy, and aims at enhancing their interpersonal effectiveness. And research has shown that helping skills can effectively be taught. The use of helping skills not only increased after helping skills training, but was also judged as being associated with higher post-training ratings of the therapeutic relationship, and also higher evaluations of session quality. As a result of training, trainees were better able to use exploration and insight skills. They were less anxious and self-critical, and they were better able to connect with patients. And further, there was a continued increase in the use of helping skills after training that was observed, and that suggests that continued practice might actually help to improve the helping abilities continuously. And lastly, but not least, one framework for guiding therapist responsiveness is termed context-responsive psychotherapy integration by Constantino, and it is a transdiagnostic if-then approach. So based on empirical associations with therapy outcome, Constantino and colleagues proposed 5 patient characteristics or treatment processes that therapists will encounter and which they need to react and be responsive to. And those are low outcome expectations, change ambivalence, self-strivings, alliance ruptures and repair, and outcome monitoring. And Westra et al. Found that when therapists succeeded in applying context responsiveness, improvements in outcome were likely. And in another study, also it was shown that to develop the skills of context responsiveness, there is a need for training methods in which therapists can actually exercise in many relevant contexts to improve their performance. They tested also a deliberate practice workshop and compared it to the traditional non-deliberate workshop for managing patients' resistance. And they found that trainees showed significantly better responding to patients' resistance, and trainees were rated as more empathic as a response to that training. So there were a couple of examples of what principle-based training can teach. And I would now, in the next question, in the next slide, talk with you about the question, what should be taught in psychotherapy trainings in the future? Maybe in addition to those trainings that are already available and with some evidence for their effectiveness. But I think to sum up this part of the webinar, it would be nice to think a bit more about what else or what should we train? Maybe things that you have missed in your psychotherapy training, thinking back.
Oh, yeah.
Yes, please.
I think one of the things that was missing in my training is someone actually watching me do therapy with someone and giving expert feedback. I think that the deliberate practice model that's being talked about a lot more recently is not implemented as widely as I had hoped. And I always talk with my own students about it's interesting the fact that there are so many people in the field who practice so regularly and for such long-term amount of time. But if no one's actually ever watched them practice, how do we know that they know what they're doing? We can't just trust that because they have a lot of years of experience, they actually know what they're doing, myself included.
Yeah, I think that that's a really great response, because I mean, supervision and live supervision are really only possible to be applied to a small subsample of the patients that we are seeing, and thus a small, just a smaller variety of situations that we encounter in psychotherapy. And there's another response.
Yes.
To the question. Yep, go
Yes.
ahead, please.
No, two issues that we have discussed a lot with David Orlinsky concerning our model of training, which is, one is the supportive elements in training, which include, we always speak of the therapist as a person, the person of the therapist. We never speak about the trainee as a person. And actually, we are building our therapeutic self. So workshops, discussion on their countertransference, on their personal feelings, on their fears at taking the first patient. And that's a very important element. And it's would be what you call today implicit learning, being cared. So you implicitly learn to care. And this we have studied, and outcome, I mean, in pre-test process, before and after, and it really increases the capacity for empathy. And the other element, which I think is essential, is group supervision, because in group supervision, you increase the number of patients you learn from, because you are small groups, no, 5, 6, but you are all discussing the same patients, the same transcripts, giving ideas and sharing fear and responsibility and joy, because very often the work of a therapist is very lonely. And so because we have been, we started with a very lonely model, which is personal supervision. So group supervision, providing personal moments for personal issues, but giving mostly group supervision is excellent.
Well, thanks. Yeah, I think you touched upon two really important topics, both the group and especially also the therapist as a person, which I think there is a lot of evidence that apart from the theoretical orientation that someone stems from, the person of the therapist has a huge effect on the patient and on outcome eventually. So thank you so much for your responses. I would like to continue and briefly
There are some
review.
answers on the chat.
Oh, sorry, I didn't realize.
Javier is there.
So individualized psychotherapy training more, and among many important things, I consider teaching self-care strategies for psychotherapists of particular relevance. Yeah, I think that's really an important point as well, like to attend to the feelings that maybe difficult feelings, maybe intense feelings that come up during therapy when encountering a specific patient, examining why this is happening, maybe how or when to communicate that or not, and ways of just really caring for ourselves, because I think it costs a lot, in a sense, to care so much for other people. It takes a lot from us as persons, and I think it's a really important comment that we need to make sure that we have enough to give, and that we also receive something, in a way, like care for ourselves first, in order to be able to be caring and be able to be caring with our patients. So thank you so much. I will now just briefly review a few key efforts to identify change processes or principles of change that are believed to be common across therapy approaches. And I think an important landmark in this effort were Goldfried's common principles in 1980, so quite a while ago, but I don't think that much has changed. And he identified 5 common principles. Those were the fostering patients' hope, positive expectations and motivation, facilitating the therapeutic alliance, increasing patients' awareness and insight, so awareness also of the connections between thoughts, feelings, needs, actions, encouraging corrective experience, encouraging patients to take risks, engage in new behaviors, and emphasizing ongoing reality testing. So helping patients to process corrective experiences and others. Then Klaus Grave was also interested in change processes in psychotherapy with the aim of developing a research-informed psychotherapy that would kind of flexibly use all empirically validated mechanisms of change in psychotherapy. And based on a meta-analysis of about 900 comparable outcome studies, he also proposed 5 general change factors in psychotherapy. Problem mastery or coping, so the patient learns to cope with a difficult situation. Clarification of meaning, where the patient gains insight or understanding of the sources of his or her difficulties. Problem actuation, which is kind of the patient's emotional experience of the problem is being activated during the session in order to kind of provide the ideal opportunity to foster change. Then we have resource activation, can be motivation or skills or strengths that are focused on, and the therapeutic relationship again. And a last effort that I would like to mention is the one that Kastongai and Butler proposed, the evidence-based principles of change, who again provide 5 categories. And they propose the patient's prognostic principles, so patient characteristics that predict good treatment outcomes, such as maybe baseline impairment, personality disorders, stages of change. Then we have the treatment or provider moderating principles, such as the ambivalence or the coping style that someone presents with. We have the patient process principles, So the patient during treatment behaviors that facilitate or interfere with improvements. Then we have the therapy relationship principles again, so elements of the exchange between patient and therapist that facilitate or interfere with improvement. And we have the therapist intervention principles. So the therapist during treatment behavior that either facilitates or again interferes with improvement. And one thing that all three of them have in common, and researching for this webinar, I came across a lot of definitions or efforts to kind of define process or principles of change. And there was one thing that I think all of them mentioned in some way or another, and that was the therapeutic relationship or the alliance in some way. So I will also in one part of this webinar focus on this aspect of, for training. In current psychotherapy training programs, and in some of your comments, we have touched upon this, transfer from theory into practice relies mainly on role-playing exercises and supervised practice, but also oftentimes it's really individual supervision, which can only be realized kind of time delayed at high cost and to a subsample of patients and relevant clinical situations. And there's not really a satisfactory training procedure by which psychotherapists can obtain this in vivo hands-on experience in dealing with a range of problems presented by a variety of patients, and in which they get this immediate, accurate and consistent feedback by someone. Yet, like you all said before, one major conclusion with regard also to this question, what contributes to the effectiveness of psychotherapy training, was that hands-on experience is a key component of learning to become a good psychotherapist. And therapists retrospectively stated that they learned the most from experiences with clients, so from actually treating patients. And that was one of the most important components of their skills training. So I think that in addition to asking ourselves what we should teach in the future of psychotherapy training, it might be an important additional question to ask ourselves, how should psychotherapists be trained in the future? What should be different? How could we give them more hands-on experiences before, or at least in the beginning of treating patients? And if there are some reactions, comments, questions, I would be really happy to hear them.
And we have a message in the chat box that says VR as a possible solution.
Okay. Do you want to outline that a bit more?
I could do that. My name is Signe Stige. I work at the University of Bergen in Norway on the program here for clinical psychologists to train them to become clinical psychologists. And we are working, of course, with these things also. And we are working now on how to supplement the other training. We don't think there is only one thing, of course. We need different things. But one thing we are exploring is, can we use VR as a way of kind of exposing our students to very realistic clinical situations before they go to meet patients? Both to kind of know how they react in difficult situations, to kind of train their way of noticing their own reactions and know how to handle them, but also we can use the same videos to practice interventions or use them to practice different things. So we are only in the starting pit of this, but we are exploring now if VR can be one like additional way to kind of develop our clinical training further from where we are now.
Yeah. So exposure to virtual reality, using that technique to help therapists in training practice.
Yes, and within a deliberate practice framework. So the virtual reality glasses are just kind of a way of kind of exposing them to realistic situations, and then we also look at the way we can train on different things with the deliberate practice framework.
Thank you so much. Yep.
Related to that, one of the things that I use I teach at the University of Pennsylvania's counseling programs, and one of the things I use is a combination of somewhat deliberate practice, somewhat Clara Hill's model. Clara Hill encourages folks to do practice sessions with real things, not simulations. And so one of the things I do with students is I have them work with each other on a real topic that's a safe topic, and Clara has a list in her text. And we actually have second-year students who deliver feedback. It's videotaped, it's time-stamped, and they're given feedback on their skills in the moment rather than after the fact. The problem is they're second-year students, so they're not necessarily super experienced. And to do that, I think you certainly need a lot more money to be able to watch all students do. And we have them do 3 sessions across time and get feedback on each session. But the idea of putting students in practicums, which is what we do, is a good idea, but most practicums, at least that I deal with, are not super warm to the idea of having their sessions taped. And that to me is one of the most difficult things, to try and get that, to do something like that in quote unquote real life.
Yeah, we just have some limitations due to reality, I think. That we always encounter, but I think it's a really great way to work with what we got and do at least the possible with the limitations that there are. Great, thanks. There were a couple more people naming, for example, deliberate practice in the chat. So thanks a lot for the feedback. I think those are really great ways of how psychotherapy should be trained ideally. I will also present in the following a couple of resources that might help to develop a 21st century online deliberate principle-based training, incorporating also the principles of deliberate practice, as well as expert training, then the huge potential of technologies, and considering the importance of flexibility and responsiveness. And I'm really glad that you all already brought forward most of these aspects. And the advantages of such a training could be that they are more easily and inexpensively distributed, that they offer time-independent use and provide kind of a cost-effective model for therapist skill advancement, and ultimately also psychotherapy success or on psychotherapy outcome. And for a long time, the field of psychotherapy research has lacked a successful model for therapist skill advancement. However, the study of expertise in other fields provides a potential model for understanding the key mediating factors involved in the development of these top-level performers in psychotherapy. Across a variety of other domains, researchers have found that engagement in this extended deliberate practice facilitates incremental development, and this results in superior performance. And here's the definition of deliberate practice by Erickson: is an individualized training activity especially designed to improve specific aspects of an individual's performance through repetition and successive refinement. And who you see up here is the group around, or is Tony Rosemanier and Alexandre Vaz, who have taken one approach to deliberate practice, and their results suggest that deliberate practice can significantly improve the effectiveness and efficiency of psychotherapy education and training. There may also be other operationalizations to deliberate practice in psychotherapy than the one that they have chosen. And I think that we should just be looking at as many ways of doing deliberate practice as possible in order to avoid that therapists are kind of too focused on specific tasks or too rigid in doing a particular intervention that they have practiced. and maybe less focused on being present, being attuned to the patient, being flexibly responsive. Also, deliberate practice itself might work in based on principles that could be enacted in a variety of ways. So, for example, maybe deliberate practice reduces trainees' anxiety, and that helps them to be more attuned to the patient. Or maybe deliberate practice encourages trainees to be less defensive and kind of more humble, or more able to admit mistakes when they happen in the process. And I think as we better understand not only how patients change, but how therapists change and learn, we will be also better able to tailor training to what therapists need, and maybe even individualize training more. What you said before in the discussion to our previous question. While prominent researchers were advocating for the use of deliberate practice in psychotherapy, there are only few examples in previous literature, and I think that one possibility offers the field of computer-supported learning, as it provides the opportunity to incorporate the principles of deliberate practice. And a next big step might be its online application, with this advantage of easy and flexible availability of the training and the time-independent use, which could help to overcome just some of the major limitations of the classical psychotherapy training. Well, the last aspect that I want to touch upon in this regard is the appropriate responsiveness and flexibility. And the definition of appropriate responsiveness is that therapists are responsive to their patients by flexibly tailoring treatment in accordance with what that patient needs in that particular moment. It could also be, in other words, kind of doing the right thing at the right time. And the need to adapt or fit psychotherapy to the individual patient has been recognized from almost the beginning of modern psychotherapy, but I think it has only recently kind of come to evidence-based fruition. So the accumulating research demonstrate that it is indeed frequently effective to tailor or match psychotherapy to the entire person, and that it may provide a strong explanation of why therapy works. In their qualitative meta-analytic review of the theoretical and research literature on therapist responsiveness, Wu and Levitt concluded that in order to be responsive, therapists need to develop awareness of and attunement to the process of therapy and to markers or of shifts in patients' experience. Well, now we want to, or we hope to consider all of these outline resources that we just talked about, that some of you brought forward in our discussions, when kind of considering a first module of this online 21st century principle-based training approach. And as mentioned before, the alliance, the therapeutic relationship, is the most, I think, agreed upon common fact or common principle of change. And as a concrete example, I will now develop and implement together with Catherine Eubanks and both of our teams the online alliance focused training, which will hopefully over the course of the next year be available under this following link. And the online alliance focused training will be modeled after the regular alliance focused training that I outlined a bit in the beginning of the webinar, with an added emphasis on deliberate practice and principles of expert training. It will be research informed and based also on prior work done in the computerized training programs. And the training will be composed of 6 sub-modules, if you want, so in a predefined order, aiming at building, maintaining, and also repairing the therapeutic alliance. So we have introduction to alliance focused training, confrontation ruptures and withdrawal ruptures, combination of both, mixed ruptures, and then immediate and expressive resolutions. And the first part of the online training consists of teaching kind of the theory, which is realized providing a great number of example videos and thereby already hoping at least to build a bridge to practice. We will choose prototypical case examples for the different forms of ruptures as well as resolutions that are provided by the developers of the concept of ruptures and resolutions as well as the AFT. And we will draw on the website from the Center for Alliance Focused Training and also an APA video series of rupture and repair in psychotherapy that was just published in 2020. And also there will be a lot of new videos that we will need to make for this training, both of patients and therapists, but then also of patients, so that those who will train can actually respond to those videos and be the therapists. So that's actually what will happen in the second part of the training, where therapists will be provided with various of those patient video scenarios and corresponding exercises of increasing degrees of difficulty will be applied. So in the beginning, there might be multiple choice with answers to choose from that are given. Then therapists need to generate responses that need to be written down and meet certain keywords. Then there will be decisions that will need to be made immediately, and afterwards their advantages and disadvantages must be reflected upon, so that then therapists can actually really practice what was previously learned with kind of an increasing degree of difficulty over time. And they will receive immediate feedback on their choices with the possibility to repeat and correct their views or reactions. And the idea is to focus on the skills in kind of a safe space or safe practice situation, so that trainees can begin to self-reflect and observe their behaviors in a supportive environment that was mentioned before also by you, before applying their work or applying the strategies to their work with actual clients or patients. And over the course of the whole training, we hope that our participants will be presented with kind of patient test scenarios where they can record their immediate reactions, and they will then be able to see their own reactions and respond to them and repeat kind of reacting to patient situations and change aspects of maybe what they did. And we hope that thereby patients can kind of attune to their internal emotional experience during the response, which might help them react in different ways in their repetitions. Then also we want to apply the rupture resolution rating scale to those test scenarios that therapists in training therapists respond to for the external validity. And now my slides won't move anymore, so I'll just give them a second. But we have the idea that it would be a 6-week training where each week another module would unlock, and where therapists will be able to train their ability to detect and repair alliance ruptures independently, but where they are reminded also by emails every week to complete the module, where the time that they spent online and the completion of scenarios and submodules will be automatically assessed, and where also we will be available with the contact for questions and technical problems as well. So you can really see this is a work in progress. We still have a lot that needs to get done, but the good thing of this is that we still have room to change things. So I would like to ask you for your feedback or a first reaction, or just whatever came up during these last couple of minutes in the webinar that you want to share with us that might help us make this an even better contribution to practice and research on psychotherapy training.
Hi, Anna. I have a question for you. All of these sounds great. I like it very much. But I was wondering what was your perspective on training regarding the face-to-face and video conference therapy. Do you think the same training is valid, or should we have specific training modules for virtual therapeutic sessions?
That is I think that overall that's something that has come up a lot in the last 2-3 years due to the pandemic, because yeah, I mean, most of us or many of us needed to switch at least for some time to seeing their patients virtually, which to my surprise didn't work so badly. I think many of us were surprised as to how well we could still at least help some of the patients that we were intending. I think that overall training should consider that. So I think there are aspects that are different and that we need to pay attention to when we don't see the patient face to face. Especially like with regard to, I think, the emotional experiences, like the kind of the deepening of feelings, that might be more difficult when you're not actually there to accompany. I don't know if necessarily this needs to be part of these online trainings, but I think that overall in training and in training research, that is something that we need to pay attention to, because I think many people continue seeing their patients virtually. Many therapists continue and will continue from the experience that overall it worked, at least with some patient populations. And I think that we should be careful in doing this without having some empirical evidence that it actually works, because kind of based on our gut feeling. So thanks, Juan. I don't know if I answered your question, but
yes, perfectly. Thank you. Thank you very much.
All right. All right. So we have some more comments here. The most important thing is to measure client outcome before and after if the training is targeted to participating clinicians. Yeah, if we can prove that outcomes actually improve, then the research will be very special. So I think that in a first step, yeah, we want to test in a kind of pilot study if therapists improve in certain skills like identifying ruptures, repairing them. And then in a second step, we want to actually, after the pilot study that we will do at Mount Sinai Beth Israel Medical Center, New York, we actually do plan a multi-site RCT on online AFT and its effects both on the skill advancement, but more importantly, on the alliance and psychotherapy outcome. And we have already found a couple of collaborators in Switzerland, Germany, and Argentina, where there are some clinics that will participate, or some training programs with associated clinics that will participate. But we are still looking for other people interested in participating. So if you are one of them or you know someone who might potentially be interested, please contact us. And it would be great to have you on board and be part of this endeavor to really test if there's also an effect on outcome and on the alliance. Are there other feedbacks on the training comments? Yep, go ahead.
I don't know if it's a question or a reflection. I don't know. It sounds very interesting, and I think it's really good that you're doing it so thoroughly, and also that you really want to do the piloting first and then try the multi-site RCT. So it's really great. And then I'm looking at this map, and then I'm thinking about culture. And then I'm thinking about how these clinical situations look in different cultures. And also, because Norway, where I work, we have a very strong welfare system. So we have noticed that when we use the FIS videos from Anderson, there is something very American about some of the transcripts that doesn't fit necessarily in a Norwegian context. So we have done our own now surveys to kind of make it in a Norwegian context. How do these difficult situations look like typically, and asked a lot of clinicians in Norway about this. So I was wondering how you had, how you are thinking about this alliance-focused training, like also in a cultural perspective, and can we make something that cuts across like context and cultures? Yeah, your thoughts on that.
I thought she stopped sharing her screen, but I think she might have lost her internet connection.
Okay.
We can wait a couple minutes, see if she comes back, which was a great question, actually, that you bring up, saying so. Maybe we could use this time to ask our audience if they would like to comment about it, if they have an opinion on the matter while we wait for Anna to come back.
I think that alliance is generally something which has been intuitive. So I think it is, I mean, the first step was to realize that this was not just a part of the landscape, but an essential part of the process and the outcome. And that was the first step. And this second step, we are sort of collectively taking of studying it and teaching it is essential. But I think that it has sometimes been overlooked, the connection between training in alliance and what we ask from our trainees about their personal psychotherapy, because in fact, this is too closely linked. And the other issue is that supervision in many countries, including mine, is not trained. I mean, you become a supervisor just because you become. There is no formal training for supervisors in many countries, which means no control. And the transferential and countertransference issues in supervision are very important and very, very little studied. So this has to do a lot with this issue, because the alliance with the patient has a model in the alliance with the supervisor. And this has not been studied practically at all, even in our international meeting, our conferences, yearly conferences. This supervision is often absent or given a very, very, very minor part of the program. And this, I think, has to do with us as a society too, because even though we may have not people offering to present this, we should provide, create in every meeting very, very steadily spaces to discuss these issues.
I was just going to suggest about the cultural question. I do think there will be important cultural differences. And I think, like, anecdotally, we've seen that already when different research groups try to do observer-based coding of ruptures. Anecdotally, they'll say, like, ruptures in my culture maybe look a little different from ruptures in another culture. Maybe they're some things seem a little more subtle or less subtle, or like what's regarded as confrontational in one culture might be different from what's regarded as confrontational in another. So I think that'll be a really interesting and exciting step in the process, will be to see, like, what does translate for everyone, and then what it needs to be really tailored. I mean, just like therapy, right? There'll be principles that are true across the board, and then there'll be that important tailoring to the individual throughout. So I think that it's just a really good reminder we have to have that in mind constantly, and always be careful about assuming, because I found this here, this is true for all human beings everywhere, anywhere, and any time, and always kind of come back to that, what's particular about this particular setting, this context, as we try to make progress on this.
Thank you, Catherine, for chiming in there for Anna in the meantime.
Anna got lost in the outer space.
I still haven't heard from Anna. I think all of her internet must have gone down. It's sadly one of the downsides to.
Well, an invitation to everybody to participate.
Yes, yes, it is. Yes, it is.
There are many people here who have a lot to say. I would like to comment a bit further since we have time. We were talking today about what students needed, trainees needed. And I remember in last year, SPR international meeting and CEPI international meeting were almost at the same time. Here she is. And in both, students, trainees, claimed for their need to be attended on their emotional needs during training. And many said in both conferences that there is a coming back to psychoanalysis because it is the school in which trainees are given room to talk about how they feel. And I think it's very important to pay attention to. Anna, you're back.
Yeah, I'm really sorry I had an internet issue, I think. So I really apologize. This was kind of my worst nightmare of what would happen, but now it happened and I survived. So it's a good corrective experience. Thanks for your patience. I'm sorry I missed some of your comments.
Hi, Anna, welcome back.
Yeah, maybe later on I can just go to the video and watch them. So I'm not really sure where we are at, but I think we received some great feedback. So thanks. Is there any other feedback or should I continue? All right. Well, then I would like to just talk with you about some broader ideas for the future of a 21st century principle-based training approach. And I think to really advance our understanding of how best to practice therapy and how to train therapists, we need to put more energy into delineating a full range of common principles of change, and we should regard what works as an empirical question. So one important future direction for principles of change would be to see others enjoy kind of the success that the Alliance has achieved in attracting the interest of researchers, practitioners, but also trainers. And as more principles of change are in a position to receive the kind of attention the Alliance has, then it will also pave the way for more research looking at their interactions, because looking at one of them at a time has the risk of overestimating the impact of one specific principle. I think we can identify principles, but to know when and how to use them would require better understanding of the variables that moderate their use. So moderators might be the difference between a particular principle being helpful and harmful. That's actually something that Catherine said to me just recently. And also given that common principles of change are common, many practicing clinicians have a lot of experience with them, and we should consider that as researchers when we further think about what to investigate. So I think researchers and clinicians can actively partner with each other through efforts such as the research practice networks, not only in the endeavor of psychotherapy training, but I think overall that would be great for the future. Well, and more concrete, when I was thinking of other modules for a 21st century principle-based training, I think you recognize a lot of the slide with the common principles, where we had Louis Castonguay, we had Klaus Grave, where they outlined a couple of other aspects that I think would be really important across different therapeutic approaches. So I think resource activation, fostering patients' hope, positive expectations, and motivation could be one other aspects that we could train therapists in broadly. Problem mastery, at least for, this might not be so transdiagnostic, but still important, encouraging corrective experiences, emphasizing ongoing reality testing. Then motivational clarification and increasing patients' awareness and insight, and problem activation or emotional affective experience. At least that's something that I find personally very important. And another thing might be case formulations that at the first look maybe are very different across different approaches, but really when we focus on principles like the stages of change or patients' interpersonal problems, they are quite common. So I think if we would find, or if we could find some common ground there, this would also be a great module. But then I'm sure you have a lot of other ideas about future psychotherapy training or research on psychotherapy training. And maybe now that I'm back, I can hear some of your valuable contributions. Well, to broaden this a bit more, and I think afterwards I will finish up and we will have a lot of time for questions, discussions, comments. There are some recommendations for future research on psychotherapy training that I found in the literature that I thought they are worth sharing. So in addition to the common principles of change that we regard as helpful, it would be important to also identify those that are harmful across therapeutic approaches to patients or to therapy, because identifying what is harmful in therapy is an important component of our ethical responsibility to do no harm. And then components of training programs need to be more clearly defined. Trainers need to specify what occurs in training so that we have an adequate picture of that training and we have kind of a chance to empirically investigate, because most of the literature is extremely vague with regard to what is actually being done in the hundreds of hours of training that therapists receive, and that makes it incredibly hard and explains maybe why there's so few evidence for what does or doesn't work. It's just a big mixture, and it's really difficult to kind of disentangle the effective components of training if we don't investigate it in a different way. Then something that was put forward by you also was that the person of the therapist is an extremely important common factor, distinct from the orientation to which they ascribe. And that's a long-standing idea that increasingly is also garnering research attention. So I think to focus on the therapist can yield creative approaches to discovering common principles of change. And we will also need more research on training advanced skills, such as managing anger or sexual attraction, maybe assessing suicidality, performing intake interviews, developing case conceptualization, and also cultural competences that you mentioned before. We need to know more about the maintenance of skills after training. So we urge everybody to examine empirically the assertion that continued practice using skills actually helps trainees maintain their skills. And I think that's a nice closing or opening statement, maybe for the discussion or the general discussion that we can have as we have some time left. That, yeah, I mean, we, I think, want to continue growing, continue improving. And the question, what do we need to do in order to actually grow, to actually improve, to actually, yeah, have more skills as therapists and have patients experience better outcomes in their therapies. I would like to thank you all for your attention. I'm really sorry that I fell out for a couple of minutes. I would also like to thank my postdoctoral mentors, Catherine Eubanks and Thomas Berger. I would like to thank my collaborators around the world that are mostly rooted or all rooted in SPR, and my students without whom none of my research would have been able to be realized. So you all helped me to do something that I'm truly passionate about, and I'm so thankful. Again, I'm really, really privileged to have been able to talk to you today, and I'm excited to continue that a bit in a more interactive manner in the next, I think, we have another 15 minutes left. So yeah, would really like to give the word over to everybody else. Quickly check the chat if there's someone.
There was somebody asking to speak, Signe. Well, she had her hand up.
Just go ahead.
I was just applauding, but I can also.
But you made it wrong. You put one hand only.
All right, now I can see those who have their camera on at least. Yep.
But I can ask a question, or I don't know if it's a question. Because I think it's so exciting what you're trying to do. And then at the same time, what we are struggling with is how do we integrate like this deliberate practice framework within the field of psychotherapy, and particularly the deliberate practice is the practicing on its own, but then how do we design practices that have the immediate feedback that is like a key mark in the deliberate practice, that from music you have it immediate because you know how it's supposed to sound, and then you play and you know immediately if you know that done it correctly or not. And we don't have this. And how can we, in this online program, for example, how can we integrate this feedback that make it possible when we practice to know, now I did it in a good way, oh no, not quite, and that we get this feedback that really make us practice within a deliberate practice framework. So it's more like your reflections or your experiences or relating to this.
I really think that's an important point, and I think it's something where we don't know enough yet. So there have just been over the last year some efforts to incorporate deliberate practice in psychotherapy, and we don't have much empirical knowledge, especially not independent of the kind of the people proposing that it's working. So we have some investigator effects also. I think also this is true for the principle-based approaches, where it would be great to have some more evidence for the effectiveness from other groups. And in deliberate practice, I think that we need to do exactly that, figure out what is helpful for psychotherapy training and what might be even harmful, especially with regard to, oh, this is what I know how to do it. Well, I would apply it to all cases independent of whether or not this is really what this patient needs in this particular moment. So something that we thought about was, in the way that there would be immediate feedback, is this computerized version. So for example, to be able to ask in this segment that you saw, what kind of rupture was present, and have like all the rupture types there, or like what marker was there, and kind of with a clear yes or no, which can be kind of where computerized feedback can be given, and thus it's really immediate, accurate, and consistent to all the therapists who do this exercise whenever they kind of want. Then when it gets a bit more complex already, when, for example, we use keywords that therapists need to kind of type in, because maybe they describe the correct thing, but they don't they don't include the keywords that we're looking for, and then maybe they don't get the exactly correct feedback. So there is something that we still need to figure out how to do. And then also we thought about, actually Catherine thought about that. I didn't even dare to use artificial intelligence or machine learning approaches to kind of give feedback on the performances of the therapists. That would certainly take more time, and we would need to kind of work on that a lot before I think that it should be really kind of released and as kind of correct feedback to therapists. What I thought about, and it comes with other problems, is that maybe training therapists in our concrete case, in this rupture resolution rating scale, for example, and have them rate their own videos. That I know there's other problems with that. However, kind of to sensibilize them as to what is going on, and kind of sensibilize them to markers of ruptures, of repair, or of ruptures, and then other indicators of repair, that they can kind of see it in the video, but also this attending to the own emotional experience during the kind of the reaction, I think is something that we could train with deliberate practice, and which would be more training this aspect of responsiveness, of kind of seeing what was going on with me, why did I maybe feel bad in that moment, and kind of self-reflect more, and use deliberate practice to practice that therapist skill, instead of practicing just kind of an intervention, which is actually what we want to get away from. We want therapists, I think, to be more free with regard to the concrete intervention, and be more attuned to kind of
exactly what is happening. But because what we are struggling with is like the balance between model learning and opportunities for model learning, and the opportunity to practice, and not only like think, but actually try to say something and react, but we need to have enough sufficient model learning to have kind of an idea what it can look like in a way. And then I was wondering, in your approach, if you are integrating that you can film your own response, and then you can look at your own response to the video, for example, because that make it possible for you, even if it's not the supervisor there, you can see things in a different way, especially if you have sufficient model learning, and like you said, you are trained to use a form or something to support the way that you're observing your own work. So
exactly, that's one idea, that therapists look at their reactions and they kind of reflect upon them, and then have the possibility to kind of correct, to kind of re-record another reaction, and then kind of compare them and see, am I more happy with my second response, and why is that?
Thank you so much. It's very interesting.
I would like to make a comment on the contents which you mentioned, Anna, and thank you very much for this very fruitful webinar. I was impressed once when I heard John Clarkin say that in the US, the only thing that was taught was psychopathology. And I always think that psychotherapy therapists should not only be experts in the past, even in CBT, it's not such a long distance past, but anyway, it's the past. You learned a wrong way of doing things. Not only experts in past and the inner world, but also experts in present and the outer world. How are you going to help a refugee from Ukraine if you only can look at his past and his feelings? I mean, he has no home, he has no food, he's lost his family. And I think this has to do with a very, I think, good choice of the US chapter, the North American chapter actually of SPR, which shows as the subject for this year's meeting. Last year's meeting was social responsiveness of psychotherapy. So when we train people, I think this issue of social responsiveness and social commitment and ethics of therapeutic pursuits should be included as an essential part of training. In some places, literature is taught because writers describe emotional and subjective states much better than manuals.
Thanks.
There's also a question in the chat box, Anna.
Sorry, there we go. Yeah, I need that.
I'll read it out loud so it can stay on the recording. It says, do you have any thoughts of using practice-based evidence to get the effect of AFT firmly established to client outcome? And it thinks, I think AFT has great potential for being impactful. And I know one study by Catherine and others in 2018 that showed initial evidence of the effect on the outcome.
Yeah, I think this is something that we would look at in a second, well, in the RCT, in the planned RCT. That's something that we need kind of more time for to do. It is really something striking that I also realized when I was preparing for this webinar, that we have some evidence for the effect of trainings on therapist skill advancement, but we don't even know if those skills actually are strongly related to patient outcome. So we just assume that, and there's definitely a huge need for an empirical association between therapist skills and outcome. And yes, that's something that we hope to establish, not now in the development phase of the program, but in the long run, because if not, yeah, it's not, maybe not worth it to invest so much into the training if then patients don't benefit. And yeah, I think that's especially true kind of for the individual patient level, because we often have kind of evidence for things working on average, but what we really haven't improved so much over the last decades is kind of reduce the amount of patients who don't benefit. And I think, especially in this alliance focused training, this is one endeavor to see, can we can we get patients, or maybe can we get patients that usually did not benefit from therapy, where it was maybe hard or impossible to establish or maintain a good relationship with the patient for therapists. Can therapists kind of be trained in that? Can they improve in that? And can we maybe in that way improve outcome and reduce kind of dropout or the amount of people who don't benefit from therapy? Juan, you have another question.
Yes, and I know we have very few minutes left, but I wanted to ask you a last question. I saw very briefly on one of your last slides that you mentioned skills maintenance or something of the sort, and I wanted to ask you about it, which I thought it was very interesting. only thought about training for young, inexperienced clinicians, but now I'm wondering if this is something that could be for all sorts of clinicians and in different stages of their career, and if training, if it would even be training at a later stage of your career, and if it would be similar to the first level. So just wanted to hear more on this matter.
Well, actually, I'm sorry that hasn't been clear enough before, and I'm really glad that you're bringing this up, Juan. Yes, our idea, our aim with this online alliance focused training, or generally the principle-based training approach, is that it is complementary and that it's not for novice trainees necessarily. I think that they can also use it and benefit from it, but that it's also for experienced therapists, and that's something we maybe need to investigate also if it has different effectiveness depending on the therapist experience level. But yes, definitely that's the idea, that it is something complementary, that we don't think that we can change the system. There's like too many other interests, I think, in the training industry, let's say, of therapists, but really that it's something complementary that therapists of almost any theoretical orientations can use and hopefully also benefit from at different stages in their careers.
Thank you very much, Anna, for your answer and for all of your presentation. We are just right on time, so maybe we should be closing up right now. There, for having some thank you messages in the chat box. Anna, this has been great. It's been a pleasure to hear about your projects, your thoughts on the audience reports have also been great. So thank you everyone for sticking with us. And Anna, for giving us that 5-minute breaks. It was actually very useful. So thank you very much. And we are almost upon Denver's annual meeting of the SPR. So I just like to remind everyone that it's going to be a bimodality event. So some of us are going to be meeting in person. Other of us will be meeting through a virtual modality. And I would just like welcome everyone to get on our social media, our social webpage, find out more about the event, where you're also going to be able to find the recording of this webinar and find out about many others. So thank you everyone once again. And Babl, you've been great. Thank you very much. And I hope to see you next time.
Thank you. Bye.